Hey everyone, it's Sarah with registerednursern.com, and in this review we're going to talk about preeclampsia and eclampsia. And as always, whenever you get done watching this YouTube video, you can access the free quiz that will test you on this content. So let's get started. Preeclampsia is a type of hypertensive disorder that occurs during pregnancy, and it tends to happen after 20 weeks gestation, so that halfway point of a normal 40-week pregnancy. So with preeclampsia, if it's severe enough, it can actually turn into eclampsia. And according to the Merriam-Webster's dictionary, the term eclampsia means convulsive state. So we want to make sure we are monitoring a pregnant woman really closely to make sure we're catching the preeclampsia condition before it progresses to this seizure-like activity where she starts having seizures, which can progress to a coma and to death. So now let's talk about the criteria used to diagnose a patient with preeclampsia. And as a nurse, the reason we want to be familiar with this criteria is because we're going to be responsible for collecting this information. And we want to know if this is abnormal, what we're getting, and what to report to the physician who can use that information to diagnose the patient with preeclampsia. So these guidelines are set by the American College of Obstetricians and Gynecologists, and there's three things that we're looking for. We're looking for hypertension, protein in the urine, and signs and symptoms that we have some type of organ injury. And this is going to make a lot of sense once I start covering the pathophysiology here in a moment. So first, hypertension. What's considered high for a pregnant woman? What do we need to be looking out for? Well, typically with preeclampsia, before that 20 weeks, their blood pressure is going to be normal. But once they hit that halfway point at 20 weeks, you will start to see it elevate. Now, according to those guidelines, it's a new onset of hypertension, and we're looking for anything greater than 140 systolic and anything greater than 90 diastolic. However, it's not just one reading. They need to have at least two readings of this that are at least 4 to 6 hours apart. Now, with severe preeclampsia, they have a severe form of it, the systolic can get as high as 160, and that diastolic can be greater than 110. Now, preeclampsia is different than gestational hypertension. With gestational hypertension, the blood pressure does increase, but they do not have protein in their urine or those signs and symptoms that are telling us that there's probably some organ injury. So hopefully that'll help you keep those two conditions separated. Then we're looking for protein in the urine, which we refer to this as proteinuria. Now most women will have the hypertension along with the proteinuria, but some small amounts of women may not have the protein in the urine. So you want to just keep that in mind. So what lab values are we looking at that's abnormal that tells us, hey, this person has some protein in the urine, this needs to be investigated a little bit more? Well, whenever a woman goes to her prenatal visit, she's always submitting a urine sample. They're looking for protein along with glucose, and we talked about why they're looking for glucose in our video over gestational diabetes. So any value greater than +1 whenever they're using a dipstick test would indicate that this is abnormal, there's protein in this woman's urine. And typically whenever that happens, the woman will do a 24-hour urine where she'll collect her urine for 24 hours, submit it to the lab, and they'll check it for protein. And anything greater than 300 milligrams is positive for protein. Or they can do a creatinine protein ratio, and anything greater than 0.3 milligrams per deciliter is an indication that we have proteinuria. Then we're looking for signs and symptoms of organ injury. And what tends to be affected with preeclampsia, as you're going to see here in a moment, is the liver is going to be affected, the brain, and the kidneys. And this can even progress to severe complications like HELLP syndrome. Also, the placenta is going to be affected, which in turn can affect the baby. So it can cause a whole variety of problems. And preeclampsia really varies among women. Some women, they'll have mild cases. Some women can have severe cases that do progress to eclampsia. Now let's talk about the risk factors associated with preeclampsia, because as a nurse, whenever you're talking with this patient, you're collecting her health history, you want to be able to identify these risk factors because it tells us, hey, we better be monitoring this patient very closely for this condition. So some risk factors include having a history of preeclampsia in her past pregnancies, or she has a family history of it. This is her first pregnancy, so first time she's ever been pregnant. She has a significant health history prior to this pregnancy. She may be diabetic, have lupus, high blood pressure, kidney disease. Obese, where her BMI is greater than 30. She's having more than one baby, twins, triplets, that increases the risk. And her age. We're talking about either being very young, like less than 18, or advanced age, greater than 35 years. So now let's talk about the pathophysiology of this condition and how preeclampsia turns into eclampsia. And to do that, we're going to take the signs and symptoms of this condition and mesh it with what is occurring in the mom's body whenever she develops preeclampsia. Because if you can understand this, there is no need to memorize these signs and symptoms. It's just going to click. So we have three key players in preeclampsia. First key player are the spiral arteries of the uterus. The next one is the placenta itself. And then the third one is mom's body, specifically her endothelial cells. So let's talk about these spiral arteries. These arteries get their name from the way they look. They are spiral, and they are found in the uterus. And they're going to play a big role in supporting this pregnancy, because whenever the trophoblast embeds into the uterus, it wants to tap into the blood supply of the uterus because it knows it's got to grow a placenta, it's got to grow a baby. And if we don't get good blood flow to the placenta, hence the baby can't really grow and develop. So we have these spiral arteries that are normally there, and whenever this pregnancy progresses, we're hitting that midway point, these spiral arteries are going to increase in their diameter. And by doing that, that increases blood flow from the uterus to this placenta. Hence, more blood flow is going to go to baby, and baby can grow and flourish. However, in preeclampsia, this changing of these spiral arteries in their size does not occur. They think the reason it possibly doesn't occur is because whenever this trophoblast embedded itself in the uterus, it did this not in a good way. It was very poor in how it did this. So we didn't get the widening of these spiral arteries. So if you don't get the increase in diameter of the spiral arteries, what's going to happen to the placenta? It is not going to get as much blood flow, and this placenta is going to become ischemic. So whenever the placenta becomes ischemic, it gets really stressed out. So it's going to release substances into mom's circulation in hopes of increasing the blood flow. But unfortunately, these substances are going to be very toxic to her endothelial cells. So as those substances are going through mama's body doesn't like it, and her endothelial cells become damaged. So if you can't remember anything else about preeclampsia, remember damaged endothelial cells, because this is where all of our signs and symptoms are really coming from. These poor little cells are damaged and we're seeing major issues. So let's talk about these cells. What are they? Where do they live? Well, endothelial cells are found inside blood vessels. So they line the inside of blood vessels. And we're talking about blood vessels throughout the whole body. And like to your organs, you have some found in your kidneys, like the glomerulus. You have them lining up through your brain, everywhere. So whenever they become damaged, that causes major issues. So what's the role of these cells? Well, two things I want you to remember that they do. One thing that they do is they control the tone of that blood vessel. So here they are, hanging out, lining the inside of it. So it controls how this vessel constricts and how it widens. However, whenever they're damaged, they're not going to have a tone because they're not there being able to line that vessel. So instead of this vessel being able to stay open, you're going to have vasospasms, hence constriction of that vessel, which is going to lead to our first sign and symptom, hypertension, elevated blood pressure. Whenever you constrict a vessel, That increases pressure within that vessel, and that's why we will start to see the high blood pressure in our patient. Now, as you know, whenever we're looking at these signs and symptoms, you will see these little asterisks by these signs and symptoms. These 3 signs and symptoms at the top are the hallmark signs and symptoms of preeclampsia. And another thing that these endothelial cells do is that they control the permeability of the blood vessel. So normally these endothelial cells are nicely knitted together and they control what they let through them and what they don't. However, whenever these cells become damaged, they're not nicely knitted together anymore. So normally substances that wouldn't leak out of them start to leak out of them. And one of those substances is protein. And as we've talked about in our other lectures, especially whenever we went over renal disease, we talked about how protein regulates oncotic pressure. So whenever protein leaves this blood vessel, water is going to follow. And this is where we're going to see these other signs and symptoms. So first, let's talk about the proteinuria. Where is this coming from? Well, in the kidneys, specifically the glomerulus, you have endothelial cells lining that glomerulus. And your kidneys normally filter your blood and it picks what substances it wants from your blood and reabsorbs it, excretes it, and just deals with it, and then you get rid of it as urine. However, normally large molecules like protein do not get filtered by your kidneys. However, whenever these endothelial cells are damaged, they are going to leak and protein can get through. So protein is going to leave the blood, it will drop protein levels in the blood, and it's going to go into the urine. Hence why this person will start testing positive for protein in their urine. Now our kidneys are not functioning like they should. We have the vasospasms going on. This is decreasing the perfusion to the kidneys. Also, from where this water is going to be leaving these blood vessels throughout the body, it's going to drop blood volume. So we're going to have less blood volume being able to be perfusing these organs, specifically the kidneys. So our kidneys aren't going to be performing like they should. So normally they would regulate uric acid levels. Instead, uric acid levels are going to increase, which is a waste product. Creatinine levels are going to increase and our urinary output is going to decrease because our kidneys just aren't functioning the way they should. So as a nurse, you want to be looking at their urinary output, strict eyes and O's, looking at that creatinine level, uric acid level. Then you'll also see edema. This is swelling. With preeclampsia, you may notice it in the face. The face will look puffy, the eyes will look puffy, and the extremities. And the reason this is happening is because of this permeability issue. We've dropped the protein in the blood because where's it went? It's left that vessel. It's pulled water with it into those interstitial tissues. So you have the swelling of the tissues present. Also, the lungs can be affected where the woman will be getting short of breath because fluid has started to collect in her lungs, so pulmonary edema. And she may notice that she's gaining a lot of weight. This is water weight from where the water has shifted into the interstitial tissue. So tell her to weigh herself every day and to watch for a weight gain of 2 pounds or more per week. Then we will also have edema of the brain. So blood flow is going to be compromised to the brain, but there's also going to be swelling of that brain tissue, cerebral edema. Because remember, we have endothelial cells up there, their permeabilities increase. And this is where things can start getting really severe and progress to eclampsia, that convulsive state. Because whenever you have swelling of the brain, you're going to see the neuro changes because our central nervous system is irritated. It is stressed out to the max. So you can start seeing severe headaches, vision changes, hyperreflexia. This is where you have exaggerated deep tendon reflexes. So one thing you want to take away from this lecture is a person with preeclampsia, you're always checking those deep tendon reflexes. And whenever we're talking about exaggerated reflexes, we're grading them like a 4+. We're checking that. We're also checking for clonus or clonus of those ankles, which we're going to talk about in depth in our nursing interventions. And whenever a patient starts having this means that there is a high risk of seizure activity. So we want them on seizure precautions. They're going to be started on magnesium sulfate, and that has its whole wide variety of nursing interventions that we're going to talk about here in a moment. Also, our liver is going to be affected as well. Swelling, it's going to be affected with its perfusion, so she can have upper abdominal pain. Also, the liver enzymes are going to be increased, like the ALT and the AST. And then a little bit more about these endothelial cells, because once we start progressing to this, we start getting into where we're having those severe complications associated with preeclampsia, like HELLP syndrome. And whenever these endothelial cells are damaged, the body wants to repair them. So imagine you have your endothelial cells, they're all damaged, and the body's like, oh, we need to send our immune system cells to go there and take care of the problem. But it actually causes more problems. So whenever these cells are damaged, the platelets are going to go and stick there trying to help with the injury to these cells, but they're actually going to cause problems. Because when the platelets are sticking together, they're blocking blood flow even more to that organ that blood vessel perfuses. Also, it's going to drop our platelet levels in our body. So she can enter into a condition called DIC, disseminated intravascular coagulation. Also, due to this damage, you're going to have red blood cell rupturing, so hemolysis. So with HELLP syndrome, I'd be familiar with it. HELLP is an acronym. The H stands for hemolysis, which is the rupture of red blood cells. EL stands for elevated liver enzymes, which we talked about why that was happening with the liver. And then LP stands for the low platelets. And that is what's occurring here with these endothelial cells. Now, some other complications that can occur with severe preeclampsia is that this placenta can actually detach itself from the uterine wall, so you have placenta abruption. Have a whole lecture on that if you want to check that out. And the baby can be affected with its growth. It can have restricted growth as well. Now let's wrap up this lecture and let's talk about the nurse's role in the treatment for preeclampsia. So we're going to take all that pathophysiology and the signs and symptoms that we just learned and put it into what we're going to do for this patient as the nurse. And to help us remember that, let's remember the word preeclampsia. So P is for proteinuria monitoring. Every visit, this patient is going to have their urine checked for protein. And some women may even be taught to check their urine at home for protein. And we're looking for those values that you can see on your screen. I had covered those earlier. So be aware of those values because that can indicate protein in the urine. Also, other prenatal labs that you want to be familiar with that could help diagnose this condition is like a complete blood count. They can look at the red blood cells because we want to see how are they doing. They can also do a peripheral smear, make sure there's no rupture of those red blood cells. Look at the platelet levels, anything less than 100,000. The BUN and creatinine, that tells us how well those kidneys are functioning. Do we have renal insufficiency? And if they suspect this patient has preeclampsia, they can look at liver function and check enzymes like that AST and the ALT, and anything greater than 70 international units per liter could indicate possibly we have liver injury. Then we have R for reflexes hyperactive, and we're talking about the deep tendon reflexes. And if these are hyperactive, this is telling us that central nervous system is stressed out, it's irritated, and we are at risk for seizures. So you want to assess that neurostatus, you want to assess for vision changes, headache, things like that. And typically, whenever that is happening with a patient with preeclampsia, they're going to be on magnesium sulfate. Now, magnesium sulfate, you can have toxicity, and you want to remember this for your exams. What are some signs that a patient is experiencing magnesium sulfate toxicity? Well, they have absent deep tendon reflexes. They're gone, or they're majorly decreased. So be on the lookout for that. Then E for evaluate for high blood pressure, because hypertension was one of those hallmark signs and symptoms. Every time a woman goes to her OB doctor, she has that blood pressure measured every visit. You also want to educate the mother how to do this at home. She can get an automatic blood pressure cuff. She can check her own blood pressure. And again, what was considered hypertension? A systolic greater than 140, a diastolic greater than 90, and it has to be at least 2 separate recordings, at least 4 to 6 hours apart. The other E is for edema monitoring. You want to teach the woman to monitor herself for this by doing daily weights. Also, you're going to assess for this every visit, every time you see that woman, and ask her, do you have swelling in your face, your eyes, your extremities? How's your weight been? Have you gained more than 2 pounds in a week? That can be a telltale sign. And how is breathing? Does she have shortness of breath? This could indicate pulmonary edema. Then C is for calcium gluconate. So why do you need to know about this? Well, this is an antidote, but what is it an antidote for? It is an antidote for magnesium sulfate, and we've talked a little bit about this, but here in a moment we're going to go in detail. But magnesium sulfate is given to help decrease the risk of seizure activity in these patients who have preeclampsia. However, there is a risk for magnesium toxicity. So on hand, you want to make sure that you have easy access to calcium gluconate in case you have to give this to your patient. L is for left side lying position, and here you can see in this picture that this person is lying on that side. The reason we want them here is because this helps with blood flow to the placenta, hence preventing placenta ischemia as much as we can for a patient who has preeclampsia. Also want her on bed rest, limit stimulation, and monitoring that fetal heart rate. And that is, you can also see that here in this picture as well. That's what's strapped around the abdomen. And teach her to report any decrease in fetal activity. A for assess for seizure activity, hence eclampsia, because this is a risk with preeclampsia. And there is a risk for seizures during and after labor, up to 48 hours. So per your hospital protocol, you're going to be assessing those deep tendon reflexes and for ankle clonus or clonus. And how you check for clonus, actually we'll be having a video on that you want to check out. But you quickly dorsiflex the patient's foot, so you point that toe upward. And whenever you do that, if it's positive for clonus, the foot will actually start to bounce back and forth like it's trying to plantar flex. And 3 bounces or beats or more is considered positive. So if you have the ankle clonus, you have hyperactive or hyperreflexia of those deep tendon reflexes, there is a high risk for seizures. Now, whenever seizures do happen with the eclampsia, early on you may see facial twitching followed with changes in their mental status, and then they'll have a full body tonic-clonic seizure. And this is where there's contraction and stiffening of the body followed by jerking of the muscles, and this can progress to a coma. Now, what is your role as the nurse during a seizure? Well, before the seizure, if you know that this patient is at risk, she has all these signs and symptoms pointing to it, you want to have her on seizure precautions beforehand. So whatever your hospital has for that, you want to read up on that. You want to have suction, you want to have things to manage that airway, padded side rails, etc. So whenever a patient does have a seizure, you don't want to leave them. You want to stay with the patient, get help. You don't want to restrain them, and you want to get them on their side, specifically their left side is best, and we talked about why that is with the placenta perfusion, but it helps prevent aspiration, helps open that airway so that tongue doesn't get back there and block the airway. And you want to make sure that you can get oxygen on them, about 8 to 10 liters, and you're going to monitor the baby, and you want to time that seizure and the characteristics of it. Also, the patient's probably going to need medication afterwards, and you want to prepare for the delivery of the baby, because with preeclampsia, the treatment tends to be get the baby out, get that placenta out, because that is where we're getting our problem, is with the placenta. So normally if that placenta baby can be removed, that will help with treatment of this condition. And this leads us to the next part of our mnemonic, which is M for magnesium sulfate. Magnesium sulfate, as I've said earlier, is administered to prevent seizures in that patient who has preeclampsia, because remember, seizures can happen during and after labor, up to 48 hours after delivery. So what magnesium sulfate is going to do, in a sense, is it's going to relax and help chill out that central nervous system that is majorly irritated, and one wrong move, in a sense, can send the patient into having seizures. But whenever your patient's on magnesium sulfate, you are going to be looking and assessing for signs of toxicity. So some early signs that your patient may be having this is that they may report that they feel warm, or you may note flushing. They can also have a decreased respiratory rate of less than 12. Their deep tendon reflexes can be very decreased or absent. So that is why we are checking that patellar reflex, the bicep reflex, looking to see how those are, and we're grading those. Also, their urinary output can be less than 30 cc's an hour, and you can notice EKG changes. P is for protein-rich diet. You want to educate the woman to eat foods that are rich in protein, because remember, we're losing protein in her urine. We're losing it throughout the body because those vessels are leaking, so it's dropping in the blood. And it's important that she eats foods that are rich in it, like eggs, nuts, meat, etc. However, she wants to watch her salt intake. It's no longer recommended that they restrict it completely, but they do need to watch it because sodium levels can increase in the blood due to renal dysfunction. Remember, the kidneys aren't working like they should, so sodium can actually increase in the blood. S is for severe complications to watch out for. So one thing you definitely want to watch out for is that HELP syndrome that I talked about earlier. Hemolysis, elevated liver enzymes, and low platelets. Also DIC, fetal distress, restriction of the growth, placental abruption, and stroke. There is a risk of that as well. I is for intake and output monitoring. Patient, we're going to monitor their eyes and nose very strictly. We want to know exactly what they're putting in and what they're putting out. This is going to tell us a lot about our renal function. So we want to monitor that urinary output very closely. Some patients may have a Foley catheter, so we can get a very accurate measurement of how much they're putting out, and we want to make sure that they're putting out at least 30 cc's per hour. And then lastly, antihypertensives. These are medications to lower the blood pressure. Some examples of this could be like labetalol, hydralazine. However, there is a fine line with these medications. They're used with caution. They're not going to be first line, because if we lower the blood pressure too much, it can compromise blood flow to the baby. But these are used in some patients, but not in all cases. Okay, so that wraps up this review over preeclampsia and eclampsia. And don't forget to access the free quiz, which will test you on this content.